I've never had introductory music like that. I feel like we should be going to battle, not listening to a talk here. But I'm impressed. I'm impressed that you guys stuck around, put dinner off for another 20 minutes to listen to a cardiologist talk about cardiogenic shock today. So I'm quite pleased that you're here. Just by way of introduction, my name is Jason Katz. I'm an advanced heart failure and transplant as well as critical care cardiologist at NYU Langone Health and Bellevue Hospital in New York. Here are my disclosures. In addition to some research and financial support, I am the inaugural president of the Society of Critical Care Cardiology and the inaugural editor-in-chief of the new Journal of Cardiac Failure Intersections. So we'll start very briefly with a simplistic, cartoonish, if you will, overview of understanding and identifying cardiogenic shock, and then we'll get into the meat of the discussion. And I've been tasked with discussing vasoactive medications and temporary mechanical circulatory support strategies. This is not something unfamiliar to most in this audience. These are mechanisms and outcomes that we share across shock etiologies, and cardiogenic shock is no different. It leads to cellular hypoxia and all of its macro and microscopic sequelae, including end organ injury, the development of multi-system organ failure, and death. And systemic tissue perfusion in every shock state is governed by cardiac output and systemic vascular resistance. Again, I don't need to share that or teach you that information. But cardiac output is very important to us. And unlike most of the cases that we've discussed throughout this conference, we're talking here about patients that happen to have impaired cardiac output due to low contractility in most cases. And that cardiac output is governed by heart rate and stroke volume, which is related to loading conditions of the heart, preload, afterload, but also contractility and chronotropic competence. And then vascular integrity, vascular tone, the systemic vascular resistance, related not just to the tonicity, but also the length of the vessel, the blood viscosity, dynamics of flow. And in shock, and in particular cardiogenic shock, one or many times both of these are significantly decreased. So if I were being simple and I wanted to give you a Google definition of cardiogenic shock, this is what I might suggest, that it's a low cardiac output state leading to end organ hypoperfusion, tissue hypoxia, and all of the sequelae I showed you earlier. But if I want to get a little attention and I want some job security, I'll show you something much more complex, that it really involves many, many different pathways that influence a downward spiral in cardiac and patient decompensation that's influenced by loading conditions, hypoxemia, cardiac ischemia, progressive diastolic and systolic dysfunction, and ultimately death. And as clinical intensivists and cardiologists, our job is to intervene on that downward sloping spiral to prevent the demise of the patient. And so I'll say you'll know it when you see it. What are some of the findings, clinical findings, that we happen to see largely in our cardiogenic shock population? And I'm a simple cartoon guy. Remember, I told you I'm a knuckle-dragging cardiologist, and many of the patients share some of the major manifestations we see in a lot of shock states. No different. Cerebral hypoperfusion with altered mental status. In this case, elevated cardiac filling pressures reflected in the elevation of the jugular veins. Patients are often tachypnic and tachycardic. Tachycardic frequently is a compensatory mechanism for a low stroke volume in a feeble attempt to maintain adequate cardiac output. They may be hypotensive, and in many cases, because of low stroke volume, will have a very narrow pulse pressure. They'll oftentimes have manifestations, in this case biochemical manifestations of end organ hypoperfusion and injury, including elevations in hepatic biomarkers, elevations in renal biomarkers. They'll have cool extremities in many cases because of this compensatory increase in systemic vascular resistance to shunt blood to the vital central organs. And we'll even have skin manifestations of hypoperfusion like livedo reticularis and other skin abnormalities. But what I've been tasked with discussing are the drugs and the temporary mechanical support strategies, and what evidence there is, in some cases quite embarrassingly little evidence there is to support the decision-making that goes around selecting these agents. And in many cases, it can be described as a little bit of eeny, meeny, miny, mo. We apply diuretic therapies to these patients, and there's not been a single study in cardiogenic shock that suggests that applying diuretic agents to these patients improves mortality. In fact, the more diuretics you apply to these patients, and oftentimes as a marker of the severity of illness, the worse patients tend to do. And we apply various strategies of decongestion through diuretic application, including the use of higher and higher dosages of loop diuretics, continuous infusion of loop diuretics, alternative diuretic agents that work at different action points along the nephron, and then continuous infusions of many different agents as well, none of which have been proven necessarily to enhance outcomes over one compared to another strategy. But it is important to know that in acute decompensated heart failure and cardiogenic shock, we oftentimes under-decongest. We under-treat these patients, and we oftentimes leave them hypervolemic even when they leave the hospital. But the goals of pharmacologic management and, yes, mechanical circulatory support is to enhance this impaired tissue perfusion, enhance tissue oxygenation by improving cardiac output, by improving blood pressure, and by decreasing the congestive profile of the patients. And we know from lots of observational data that vasoactive medications are part of the armamentarium of an intensivist or cardiac intensivist who is caring for cardiogenic shock patients. In this study from the Mayo Clinic, 1 out of every 4 patients received a parenteral vasoactive medication that is in the cardiac ICU, most of these patients with cardiogenic shock. And in this contemporary CICU registry from the Critical Care Cardiology Trials Network, a trials network including now upwards of 40 high-volume North American sites, of which I'm one of the executive board members of this registry and trials network, we showed that all patients with cardiogenic shock receive at least 1, and in many cases 2 and 3 vasoactive medications as part of their management scheme. And the goals of management are multifactorial. We can apply vasoactive medicines like vasopressors or vasodilating agents to increase or decrease vascular tone, depending on the specific pathology of the patient, inotropic agents that enhance contractility, and vasopressors, which can enhance vascular tone, as well as diuretics, which lead to decongestion. I don't have to go over this with your audience here, but most of the agents that we use act on the adrenergic receptors, and it's important to go back to medical school or nursing school or undergraduate where you learned about this to remind yourself as you select the appropriate first and sometimes second and third vasoactive medications. And they act quite differently. And so I'm a big proponent of choosing a pharmacotherapy or pharmacologic strategy that counteracts the pathophysiologic actions from a hemodynamic and adrenergic perspective in the cardiogenic shock patients. So we have dopamine that enhances dopaminergic activity. We have a number of agents that either increase or decrease systemic vascular resistance. There are a number of key randomized controlled trials of vasoactive medications in cardiogenic shock, a number of them that really haven't really influenced management, though. And so there is a dearth of profound evidence to support the use of these agents. It goes back to that first slide. It's a little bit eeny, a little bit meeny, and a little bit mo. The Capital Do-Re-Mi trial is the most sort of contemporary study. It was a single-center comparison of dobutamine versus milrinone, 2 commonly used inotropic therapies for cardiogenic shock in North America, and they showed that there was no difference in mortality or any significant difference in adverse events when choosing one versus the other agent. There is a multi-center study, the SOAP-2 trial, which I'm sure many of you are familiar with, but there was a secondary analysis looking at the small subpopulation of patients who happened to be enrolled with cardiogenic shock. This study compared dopamine with norepinephrine and again found no difference in mortality, although an increased risk in arrhythmic events with the use of dopamine, particularly in the cardiovascular or cardiogenic shock subgroup. This has led to practice changes across sites, despite the relative limited robustness of this outcome. There are studies like the Optima CC study and the Katz study, again examining epinephrine and norepinephrine, neither of which showed demonstrable differences in mortality. And you're looking at it. This is the randomized controlled trial data or secondary analysis data looking at vasoactive medications in cardiogenic shock. We do know that epinephrine, if frequently chosen as a first agent, can lead to higher lactic acidosis development, Again, you saw on the prior study no demonstrable endpoint difference, but if lactate or early lactate rise is a concern for you and your patients, perhaps that is an agent to avoid. So how do I make an informed decision despite a very limited, tenuous evidence base? Well, again, I try to match pharmacology with pharmacologic endpoints. What is my goal? Is cardiac contractility the problem that I want to most address? Then I might use a vasoactive medication that has predominantly inotropic properties, dobutamine, milrinone, dopamine, epi or norepi. Is afterload or preload, is the congestive state of my patient the primary target that I want to modify with a vasoactive medication? In that case, I might use agents that provide, in many cases, more pronounced vasodilatation that counteract the dysregulated increase in systemic vascular resistance we oftentimes see as a pathologic consequence of preservation of systemic perfusion. In that case, we might use an agent like nitroprusside or nitroglycerin or an inodilator like dobutamine or milrinone, and then, of course, diuretics to decongest the heart. And if mean arterial pressure is the target that I want to influence, then I might choose an agent that has vasopressor properties like epi, norepi, vasopressin, or even dopamine. Moving forward, there is an ongoing trial that's enrolling capital Do-Re-Mi 2. This is the first trial that is looking at randomizing patients in a placebo-controlled fashion. I don't think I can go backwards. To milrinone or dobutamine versus placebo in patients with cardiogenic shock. So we may know a little bit more. It's not even clear at this point whether any inotropic agent influences or improves outcomes, although it's a common agent in our clinical armamentarium. So that's it. That's all we know about vasoactive medications in the contemporary management of a cardiogenic shock patient. There is still tons to learn, especially now in an era where we're balancing this with temporary mechanical circulatory support strategies. How do we choose these agents? Do we choose these agents? Do we go to a mechanical strategy first, or do we use a vasoactive therapy first? And how do we use them together? We commonly employ agonists of the adrenergic receptors, but it's important to understand the mechanism of action for each and every one of these drugs, and every drug has a side effect. And in these critically ill patients, in whom still about 50% die when they come to the hospital, the adverse events or adverse effect of these agents are clearly magnified. I will tell you and remind you that no single drug has been shown to substantially influence mortality when compared to another agent. And again, the side effects are common. But they're all necessary evils to maintain some stability and to achieve some homeostasis in patients. And again, we're only talking about vasoactive medications. We're not addressing any of those other pathways which I showed you in that very complex slide in the beginning. So we didn't even talk about other vasoactive medications like pulmonary vasodilators, levosimendan, which is not available in the United States commercially, or drugs that act on alpha agonists, particularly like midodrine. Ultimately, I do believe that shock phenotyping, an understanding of severity and timeliness of intervention, and etiology will all matter. We just ultimately need to develop the evidence base to prove that. And until then, it's all a little trial and error. But at least I encourage you or implore you to try informed trial and error when selecting an agent. So that's pharmacotherapies. What about temporary mechanical circulatory support strategies? Despite, again, a very limited evidence base, we clearly use these more and more. This is data from a North American registry, and it only goes back to early 2010s. I can assure you that this trend has continued, such that there's been a rapid increase in the use of temporary mechanical circulatory support strategies for the failing heart in the setting of cardiogenic shock. What are the potential indications for a temporary mechanical circulatory support strategy? It would be cardiogenic shock that's refractory to maximal medical therapy, patients who have severe unrelenting hemodynamic instability, patients in whom end organ injury would preclude the consideration of a durable mechanical circulatory support strategy or heart transplantation as an escape route, patients who may have cardiac arrest or unknown neurologic status. And the primary goals of these therapies are what you think that they might be: to increase systemic and end organ perfusion, to enhance coronary perfusion to reduce cardiac ischemia, to reduce ventricular volume and cardiac filling pressures in order to reduce wall stress, to enhance stroke volume, and in particular to reduce myocardial oxygen consumption, and to reduce myocardial ischemia by maximizing energy supply while minimizing the heart's demand. We employ these for a variety of different strategies. We may use it as a bridge to recovery. Imagine your patient that comes in with COVID or flu myocarditis. The goal is to apply these therapies to maintain some normal homeostasis until the body can start getting better, and then we wean it and remove it to aid in recovery. In the U.S., it's frequently a bridge to a durable support strategy like a durable left ventricular assist device or transplantation, and in some cases it is a bridge to decision. And what we unfortunately do far too often with these temporary devices, but what it should never be, is a bridge to nowhere. What temporary mechanical circulatory support strategies do we tend to employ? We have balloon pumps that were first developed in the 1960s that inflate during diastole to largely enhance coronary perfusion and deflate during isovolumic contraction to reduce afterload and improve cardiac output. And they have a hemodynamic impact that's determined by four major factors, and in particular, the magnitude of diastolic pressure augmentation. And despite neutral or negative trials with balloon pumps and cardiogenic shock, this is the one variable that is not routinely collected, but probably the variable which we've shown that is probably most influential in aiding the hemodynamic response. Because you'll frequently hear that a balloon pump only augments cardiac output by about half a liter to maybe 0.9 liters per minute. But there are so-called super responders. These are the patients who get profound augmentation of the diastolic blood pressure. These are the patients that do well. And the failure to capture this, I think, is one of the things that are undermining contemporary balloon pump trials. There are tandem heart devices that provide extracorporeal left atrial to femoral artery bypass using a centrifugal flow pump to drive blood through the circulation. These work well, but they require a transeptal puncture, a patient that tends to be sedated, mechanically ventilated, and sometimes paralyzed to prevent migration of the device. And they require large cannulas that can cause injury to the vascular access sites. And now there are the Impella platform of devices, a much easier to use device that goes retrograde across the aortic valve. The Impella CP device provides about 3.5 liters per minute. The 5.0 and now the 5.5 device provide up to about 5 liters per minute. We're talking exclusively left-sided support. There is an Impella RP Flex that provides right-sided support as well. This is the microaxial flow device that was shown in the recent Danger Shock trial to improve outcomes. The first randomized controlled trial of a temporary mechanical circulatory support strategy in cardiogenic shock that improved patient outcomes. This study was well done, well executed over 12 years to show that the Impella CP device improved outcomes out to 180 days. Prior studies looked at much shorter outcome duration. This looked at death from all cause at 180 days. And even though so well executed in a positive study, the results were fragile. 4 patients, if they had gone from survival to not survival, would have made this a negative trial. And then there is, of course, the use of extracorporeal membrane oxygenation in the central or peripheral cannulation that provides emergent cardiopulmonary support. It removes blood from the venous circulation, oxygenates that blood, removes carbon dioxide, and then returns it to the arterial circulation, leveraging in the contemporary practice all centrifugal flow pump technologies. These are preload dependent and afterload sensitive devices and certainly have their relative contraindications. They do reduce both right and left ventricular volumes. They do enhance systemic perfusion, but at least many people feel that it comes at a consequence. It pressurizes the aorta. It increases afterload. It increases systemic vascular resistance, and that it leads to increases in LV wall stress in an already injured heart. That is, unless there is LV venting. But I will tell you that in many cases, there is the universal truth that VA ECMO doesn't unload the heart, and then there is the clinical and contemporary practice truth, and that in some cases it does. Despite the fact that it does pressurize the aorta, it does reduce ischemia and may attenuate the systemic acidosis, and may enhance tissue perfusion, and may reduce arrhythmic burden and improve volume removal, all of which can lead to ventricular unloading. But the goal is, like any temporary device, is to do enough, not more than enough, Never in the history of critical care medicine has targeting supraphysiologic endpoints been a good answer. No, we do enough to provide support for the heart and lungs, to protect the organs, and then to determine an exit strategy, which in many cases is transition to a durable exit strategy like LVAD or transplantation. And then finally, it's important to remember with all these temporary devices, and this is a rule that you can take to the bank, the longer that the device is in, the greater the likelihood there is to be a complication. And so as soon as you start that temporary MCS for the management of your cardiogenic shock patient, you better be thinking of an exit strategy because a complication will indeed occur. Many of those are a balance in hemocompatibility between the risk of thrombosis and bleeding. But there are many other potential consequences, including the development of end organ dysfunction like acute kidney injury, some of which requires renal replacement therapy, infection, neurologic injury, etc. So how do I decide with a pantheon of increasing devices that become available to us cardiologists in the cardiac intensive care unit? I'm a less is more kind of guy. I do enough. I determine a strategy based on clinical and hemodynamic variables. I institute that therapy based on the availability of those resources at my institution, and then I'm prepared like a good Boy Scout. If the patient does well, I'm prepared to de-escalate their therapy. If they're not doing well despite the decisions I make, I'm prepared to pivot, and I work as a team. And my completely biased opinion is that a jack of all trades is a master of none, and it's impossible to be great at all these things, so you should be good at least one or two of these devices, and that's what you should get practice with. And it's not just you, it turns out. It's you and your team and your bedside nurses and your perfusionists and everyone else. I use invasive hemodynamics quite frequently to monitor their patients. I don't believe in one special number, one magic number that I'm targeting, but rather I follow the trends like the stock market. I stabilize the patient, I watch, I reevaluate, I watch, I constantly reevaluate, and again, I think about that exit strategy, and I'm prepared to pivot. And then once in the ICU, I start evaluating trends to see if my patient is getting better or not. That means improvements in vital signs. That means improvement in markers of systemic perfusion. That means improvements in markers of end organ function, the ability to attenuate the acidosis, the ischemia, and the congestion. And so what are my conclusions at this stage, 2025 at ISACHEM, on temporary MCS strategies? Well, there's still a lot to learn about temporary MCS, much like there is about vasoactive medications. Randomized data now suggests that there may be a benefit with a microaxial flow device, but it's important to remember that this is in cardiogenic shock complicating acute myocardial infarction. And guess what? It turns out that most of the cardiogenic shock we see in our ICUs is not related to acute myocardial infarction anymore, but rather in the setting of heart failure, either acute on chronic heart failure or de novo heart failure. And there's still much we don't know about that patient population, but I can tell you they behave differently, they consume different resources, and they have different outcomes. Illness severity and phenotype should help to inform temporary MCS decisions, and monitoring and reevaluating is critical. And then it's important to remember that as soon as you put this strategy in, this temporary device in, or start any vasoactive therapy, the complications are going to happen. And so be prepared to exit and be prepared to deal with those. And I'll end on this last slide. This is something we published in the Journal of Cardiac Failure, something that tends to challenge contemporary trials in cardiogenic shock. This is a play on the Schrödinger cat analogy in quantum physics, whereby, if you may remember, that there's a closed box where there's a cat and there's some lethal mechanism. And at any one time, because you don't know whether the cat is alive, the cat is existing in this alive or dead state, and you won't know until you open it. And I sort of feel like that's the cardiogenic shock patient, that we oftentimes don't get them to sort of later in their stage when they may have developed unrelenting refractory end organ dysfunction that may not make them a candidate for downstream resources like LVAD or transplant. Or they may have psychosocial barriers that prevent a downstream resource. Or they may be too far down the pathophysiologic pathway to salvage them. But you don't know until you open the box. So we really need to sort of think about this strategy when we develop clinical trials. Understanding, identifying cardiogenic shock earlier, and leveraging therapies or studying those therapies earlier in the pathway, and then really thinking more strongly about what are important endpoints and outcomes for these patients. A couple of sort of bias slides here. This is the new Society of Critical Care Cardiology. One of the reasons I was excited to be here, I'm usually at cardiology conferences where it becomes a bit of an echo chamber. We just talk to each other and we say the same thing over and over and over again. That is not the case here. I think I might be one of the very few cardiologists here, and we love to partner with you in this society. And then this is the new Journal of Cardiac Failure, Intersections, where I'd love to see your work and publish it, especially at any place where there are intersections with cardiovascular physiology, cardiovascular pathology, particularly in critical care medicine. So thank you very much.